Welcome back from spring break. We're going to begin now on Chapter 14, the personal context of later life, physical, cognitive, and mental health issues. So let's think about what words can you think of that are associated with older adults? What are some health issues that older adults are faced with? And what happens to cognition in older adulthood? We'll be exploring that through this chapter lecture. And finally, we'll look at what are the characteristics of older adults in the population? And how long will most people live? What factors influence this? So let's look at the demographics of aging. There have never been as many older adults alive as there are now. So you will see many more older people than your great-grandparents or even your parents did. Better health care and lower childbirth mortality rate for women is responsible for a large population of older people in the United States. In the United States, the sheer number of older adults will place enormous pressure on pension systems, social service systems, and the healthcare system. So let's think about, especially Social Security. Will there be enough when you guys get older? Healthcare, especially Medicare and Medicaid and long-term care. With more older adults, will there be enough money to have insurance for all those people and other human services? The costs will be borne by small cohorts of taxpayers workers behind them because more and more people will be retired and paying less taxes. It'll be your generation paying for my generation now. The growing strain on social service systems will intensify because the most rapidly growing segment of the U.S. population is the group of people over age 85. The number of such people will increase nearly 500% between 2002 and 2050, compared with about 50% increase in the number of 20 to 29-year-olds in the same period. So there's going to be 500% more older people and only about 50% more younger people. You do the math. That's not, how are we going to support that? Individuals over age 85 generally need more assistance with daily living. They get more social services, right? Medicare, Social Security, and in turn draining the social systems, including the healthcare system. So now we're going to look at some demographics of aging. So note the changing shape of distribution in terms of the proportion of the population that is young versus old over time, and as a function of whether countries are considered developed or developing. So we're considered developed, and you could think of, developing countries that are those smaller countries that we talked about earlier. So this figure shows population pyramids for the most developed and least developed countries combined around the world. Let's look at developed countries first. They're designated by the darker color in the figure. In the middle of the 20th century, there were fewer people over the age of 60 than under age 60. So the figure tapers towards the top. Comparing this to projections for 2050, you can see that a dramatic change will occur in the number of people over 65. These changes also occur in developing countries. The figures for both 1950 and 2014 look more like pyramids because they are substantially fewer older adults than younger people. But by 2050, the number of older adults in developing countries will have increased dramatically, changing the shape of the figure. So let's look at this figure. Notice the changing shapes of distributions in terms of the proportions of the population, right? Young versus old over time, and as a function of whether countries are considered developed and developing. So this one's going to look at population, and you can see in developing countries, they mimic a lot of like what we look like in the 50s. There's greater population, and the younger you are, and as you age, it slowly deteriorates. If you look in developed, that's not what it is anymore, right? So the middle age actually has the most in population, and it kind of gets smaller as you get to those top tiers, but way different. So that's definitely going to put a burden on our healthcare, our socio-economic systems. Now we're going to look at the projection of between developed countries and developing countries for the year 2050. So you can see that even developing countries, they're going to have more overall population, but they're still retaining that pyramid shape. So it's a gradual increase. And again, we're all going to show that greater increase in population, but we, as in developed countries, continue to have those large population of adults, middle, young. You can see 60 to 64 is the greatest amount of people. So that's when 69 is when people start taking Medicare, Social Security, 65. That's going to be the biggest strain on our economy and our healthcare. So what do we do? How do we fix those problems? Something to think about, especially your guys' generation. So we know that the population is getting bigger every day. There's over 8 billion people in the world, and a large proportion of those people are older or aging adults. But it doesn't answer the question, what will older adults look like in the coming decades? So by 2030, it is estimated that 85% will have a high school diploma and about 75% will have a college degree. So this is just a graph demonstrating the proportion of older adults, 65 years and older, and how it's increasing and continues to do so in the coming decades. So you can see that Japan, like we said, has going to have a 2-to-1 ratio over from 60-year-olds to younger, is in the top, and India is at the bottom. So we're somewhere in the middle of how our demographic of aging is increased. What will it look like in the next 30 years? So we know that we have a huge population, not just in the United States, but in the world. And we're going to have many more older and late adults. So what does that mean? It means that there's going to be more longevity, right? The number of years a person can expect to live. And it's determined by genetic and environmental factors. We're going to go over the 3 types of longevity and what that means. The first one is average life expectancy, or median life expectancy. And it's the age at which half of the people born in a particular year will have died. Average life expectancy at birth for people in the United States has increased mainly due to significant declines in infant mortality and in the number of women dying during childbirth. So less women dying in childbirth, more women living, right? More population. Elimination of major diseases, like I talked about earlier, vaccines. We know how to treat polio. We know how to treat cancers now, pneumonia, things that people would maybe have died of the common cold. And improvements in medical technology. We have CAT scans, MRIs. We can catch strokes earlier. We can catch cancers earlier. And as a result, people are living longer. Currently, average life expectancy at birth for American women is 81 years, and for men it's 76.2 years. The next type of longevity is useful life expectancy, and it's the number of years that a person is free from debilitating chronic disease and impairment. Ideally, useful life expectancy matches the length of a person's life, right? You only want to live as long as you have good quality of life. However, medical technology sometimes enables people to live on for many years, even though they no longer are able to perform routine daily tasks. You see this all the time at the nursing home. They're sitting in their wheelchairs, they can't talk, they can't speak, they can't eat, they can't walk. Is that the kind of life that you envision for yourself? Accordingly, when making medical treatment decisions, people are now placing greater emphasis on useful life expectancy and less emphasis on the sheer number of years they may live. It's more of a question of quality of life versus quantity of life. So remember that question I asked at the beginning of the semester? Do you want to live a long life even if you are debilitated? That's what useful life expectancy is. We're asking those, what is the amount of years in life can you live a productive and healthy life? And the last thing we'll look at in longevity is maximum life expectancy. And it is exactly what it says. It's the oldest age to which any person lives. So think about that lady we talked about in chapter 1, how old she was. Currently, scientists estimate that the maximum limit for humans is around 120 years, mostly because the heart and other key organs cannot live past that because they'll need to be replaced. So the question is, do you want to live to 120 years? Only if you have a good, useful life expectancy? Think about it. So this graph is a good example of showing that life expectancy. It gives you life expectancy at birth and life expectancy at 65 years in the United States. And it looks at from 1900 to 2010. And you can see that if you take it from birth, we've got a lot more increase in that life expectancy. And a slightly more increase in life expectancy if you look at it at 65. You can see especially in the 60s, between the 60s and the 90s, that really increased that gap increased. But it's a good way to see that overall life expectancy, whether you look at it at birth or if you start looking at it from 65, it's increased from 1900, well really about 1900 to about the 1930s, it looked like it started to increase. Another factor in longevity is heredity. Have you ever heard someone say, I have good genes? My grandfather smoked and drank every day and lived to be 100. Or vice versa. My grandmother didn't smoke a day in her life and got lung cancer at 60. These factors may be due to heredity and passing along good genes. Remember that lecture on genes? We get a lot from our family. We have known for some time that a good way to increase the chance of a long life is to come from a family with a history of long-lived individuals. Look back at your family. Do you have a lot of long-living individuals? Think about their lifestyle. Was it genes or lifestyle? That brings us to environmental factors, right? That lifestyle is one of them. They include diseases, lifestyles, toxins, social class, etc. Some of these causative factors are obvious. As an example, the impact of social class on longevity results from reduced access to goods and services, especially Medicare. But even healthier foods cost more money. If you want fresh produce, they cost more money. Fast food is the cheapest way to go, and it's also the most unhealthy, right? So that socioeconomic still plays a huge factor in lifestyle choices, diet, health, and access to medical care. And we know overall, healthier lifestyles reduces disease. Ethnic differences exist in life expectancies. Latino Americans have higher life expectancies than European Americans at every age, as do African Americans once they hit age 85. So although African Americans start life with lower average longevity than European Americans, by age 85, they typically outlive them. Latino Americans, like we said, expect to live longer than European Americans at every age. Why do you think that? So we asked the question earlier, why do women live longer than men? Women's average longevity is about 5 years greater than men's at birth, narrowing to roughly 1 year by age 85. These differences are fairly typical of most developed countries, but not of developing countries. Why? It's a good question. One of the reasons could be the death in childbirth partially explains the lack of female advantages in developing countries, right? They have a higher death with childbirth. And remember, that was one of the factors in developed countries of why people are living longer, less death in childbirth. So if they're still experiencing that, they're going to have, they're not going to be showing that women live longer in those developing countries because they're dying early. It also may result from infanticide of baby girls, where they're killing baby girls because they want a male heir. Happens in a lot of developing countries. So what accounts for women's longevity advantage, especially in developed countries? Well, overall, men's rate of dying from 12 of the top 15 causes of death are significantly higher than women's at nearly every age, and men are more susceptible to infectious disease. So let's think of what are some of the top causes of death. We've got strokes, lung disease, cancer, heart attacks. If you think of that, men are dying more from that than women. And when they get infections, they're more susceptible to infection. So if you top those two together, they just have a tendency to have a higher mortality rate. So the better question is, why are men getting these diseases more often, and why are they more susceptible? So this map shows longevity across the world, right? It's an international data on average life expectancy at birth. So notice the differences between developed and developing countries. So you can see that high life expectancy is in the purple and the blue, and you see the United States, Australia, China, and then anything in the yellow, orange, red, that's the lower life expectancy. So you see a lot of that in Africa. So why would you think about Africa having lower life expectancies? Some of the reasons may be access to clean water, access to good medical care, vaccines, um, technology, early detection of diseases, all that, right? Access to nutrition, proper nutrition, and socioeconomic, all those things play a factor. So they almost mimic what we look like in the 50s in their life expectancy. Countries around the world differ dramatically, right, in how their population live on average. So the current range extends from about 59 years in Uganda to over 83 years in Japan. Such a wide divergence in life expectancy reflects vast discrepancy, like we talked about, in genetics, sociocultural and economic conditions, healthcare, and diseases across developed and developing nations. So when you think about it, think about those problems we thought about it with Africa. Poor nutrition, poor access to good nutrition, not having clean water, not having vaccinations, good medical care, good technology, poor socioeconomic and cultural, and then maybe just genetics, right? So now we're going to move on and look at the physical changes and health changes in late adulthood. What are the major biological theories of aging? What physiological changes normally occur in later in life? And what are the principal health issues for older adults? I want you to think about your own family. Remember looking at old pictures of your parents and maybe your grandparents? What did they look like back then compared to now? What physical changes do you notice? Why do you think they occurred? As we go over this section in the lecture, we'll consider these changes as well as things adults can do to improve their health. But first, let me ask you the basic question. Why do people grow old? Why does everyone who lives long enough grow old and eventually die? There is no adequate theory or explanation. Why don't we all live forever? So scientists and theorists have thought about it, and they've come up with two theories of possible reasons why. The first one is the program theory, and it suggests that aging is due to a biological or genetic program. Researchers now believe that the decline in functioning in the endocrine system and the immune system may be part of a master genetic program, a kind of biological clock, you could say. For example, program aging appears to be a function of physiological processes, the innate ability of cells to self-destruct, the clock-like changes in some hormones, the decline in effectiveness of the immune system, and the ability of dying cells to trigger key processes in other cells. So in other words, there's a gene in your body that at a certain age gets triggered, and it sends it to the your endocrine and your immune system to stop functioning correctly, stop repairing cells, stop dividing cells, to trigger other cells to grow. So it's like a little time clock that's set off by one gene sets it off, but they don't understand why. They don't know how this self-destruct program is activated, nor do we understand how it works. They just theorize it. Another theory is damage or error theory. So one of those is, there's many under this. So one is wear and tear theory, which suggests that the body, much like any machine, gradually deteriorates and finally wears out. So this would be that osteoarthritis we learned about last chapter, the wear and tear of your joints. Just like you would wear out your engine parts, you'd wear out your ligaments, your bone, that same idea. The second subset of damage or error theories is called cellular theories. And within these cellular theories, they're explained the aging process by occurring within the individual cell. So it occurs inside the cell. It results in buildup of harmful substances or deterioration of cells over a lifetime. And then the next step will go through how that happens. So some researchers believe that free radicals, or chemicals that are produced randomly during normal cell metabolism, that bond easily to other substances inside cells, can cause cellular damage that impairs functioning. So according to this theory, aging is caused by that cumulative effect of these free radicals, so that those randomly produced, over metabolized cells that have these free radicals, and they increase over lifespan. Free radicals may play a role in some diseases such as atherosclerosis. So if you're having a lot of extra production of these free radicals and cause blockage in your arteries, which is atherosclerosis, and which could in turn result in a stroke. So eating a healthy diet may postpone the occurrence of some of these age-related diseases. So you prevent that. Another cellular theory focuses on cross-linking. This means that proteins interact randomly with certain body tissues, such as muscles and arteries. So the results of cross-linking is that normal elastic tissue becomes stiffer. So if you're thinking about a muscle or artery, it becomes less flexible over time. So the result in some cases can be serious. For example, if your heart is a muscle, so if that becomes stiff and less flexible, the heart has to work harder to pump, which may increase the risk of heart attacks. And if you're getting less blood flow to the brain, age-related brain disease. So very important. And finally, a cellular theory focuses on the number of times a cell can divide. So we talked about cells needing to divide to produce healthy cells to repair, right? That's how your body repairs. So when you presumably limit the number of times a cell can divide, it can limit the lifespan of a complex organism. What causes cells to restrict their number of divisions? Well, evidence suggests that the tips of the chromosome, called the telomeres, they play a major role in aging by adjusting the cell's response to stress and growth stimulation. And it's based on cell division and DNA damage. So an enzyme, and it's called telomerase, is needed in DNA replication. So you need that to reproduce that DNA. To fully reproduce the telomerase, which happens when cell divides. So every time the cell divides, you're reproducing that DNA. But telomerase is not normally present in somatic cells. So with each replication, the telomerase becomes shorter. Eventually, the chromosomes become unstable and cannot replicate because the telomerase becomes too short. So if it's too short, it can't replicate. And if it can't replicate, it can't heal and new tissue can't survive. Some researchers believe that cancer cells proliferate because they can activate telomerase. So research on effective cancer therapy may involve targeting these telomerase. Chronic stress accelerates changes in telomerase, thereby shortening one's lifespan. So it's one of the ways that stress can affect you physiologically, right? So other research indicates that aerobic exercise may help maintain the telomere length, which may also help slow down the aging process. So some theories on why we don't live forever. So let's look at the physiological changes on a neuro basis. Neuroscience research indicates that the most important normative change with age involves in the structure of neurons and how they communicate. So above is the picture of the basic structure of the neuron. Remember that from earlier in chapter 3? Each of the 3 changes we consider in this section, which we'll go over later, neurofibrillary tangles, dendritic changes, and neuritic plaques, impairs the neuron's ability to transmit the information, which ultimately affects how a person functions. So think about this compared to a newborn in the beginning of these connections. What happens when these die? So remember, we have the cell body, the dendrites, we have that axon, which you can see through the picture. That's where the direction of information flows. And then at the terminal buttons, we have those little areas where the neurotransmitters are going to communicate that information. So we're going to go on the next slide and kind of explain what happens with those changes. So the changes that impair the neuron's ability to transmit information leads to a decline in a person's function. For reasons that are not understood, fibers that compose the axon sometimes become twisted together to form a spiral-shaped masses called neurofibrillary tangles. These tangles interfere with the neuron's ability to transmit information down the axon. So remember, that axon is where we transmit that information. If it becomes tangled, think of that tangled cord. It's very hard to transmit information. Some degree of tangling occurs normally with age, but large numbers of neurofibrillary tangles are associated with Alzheimer's disease and other forms of dementia, which we'll talk about later. Changes in the dendrites are more complicated. Some dendrites shrivel up and die, making it more difficult for neurons to communicate with one another and transmit information. However, research indicates that dendrites continue to grow in some areas of the brain. And embryonic stem cell research indicates that inducing growth may be a future way to treat brain disease and injury. So remember, embryonic stem cells, those stem cells coming from the umbilical cord that have not had a predetermined function yet, so they can become anything. So this function of the dendrite may explain why some older adults continue to improve in some areas, as we'll talk about in a little bit. Why some dendrites degenerate and some do not is poorly understood, and it may reflect the existence of two families of neurons. So remember, the dendrites is where they receive the information. So if those shrivel up and die, that cell is not going to receive information. Damage of dying neurons sometimes collect around core protein and produce neuritic plaques. So if they're dying neurons, so if they start to die, what happens to them? They create these plaques. And plaques likely interfere with the normal functioning of healthy neurons. So they just get in the way. If you have a dying neuron and it becomes a plaque, that can't give that transmission to the healthy ones. Although a large number of plaques are considered a definition criteria of dementia, researchers have not established what's considered an allowable number of plaques that indicate a healthy aging brain. But I will say that having a significant amount of plaques is the definitive definition of having Alzheimer's. So when they do that autopsy and look at it, that is what they're looking at. Because neurons do not physically touch one another, they must communicate via chemicals called neurotransmitters. So remember, those are at the ends of those terminal ends. With age, the level of these neurotransmitters decline. These declines are believed to be responsible for numerous age-related behavioral changes, including those in memory and sleep, and perhaps for diseases such as Parkinson's. If they can't transmit those needed chemicals, those needed neurotransmitters, you're going to see a lot of deficits. Through technological advances in non-invasive imaging and in assessing physiological functioning, we are learning a great deal about relationships between changes in the brain and changes in behavior. Neuroimaging is an important tool for understanding both normal and abnormal cognitive aging. So remember when I talked about earlier in the semester about that functional imaging and being able to link the behavior with the brain? That's what they're going to talk about. So two neuroimaging techniques are used. So structural neuroimaging provides highly detailed images of anatomical features in the brain. The most commonly used ones are X-rays, computerized tomography, which is a CT, and magnetic resonance imaging, which is an MRI. So structural neuroimaging, so you got to think about it, it's like taking a picture. So it's effectively identifying things such as bones, fractures, tumors, and other conditions that cause structural damage of the brain, such as strokes. It can see the bleed. Functional neuroimaging provides an indication of brain activity, but not the anatomical details. So this is what I'm talking to you about, seeing the actual brain activity. So it uses a single photon emission computerized tomography. You can have a functional magnetic resonance imaging, an fMRI, and there's many different other types. But you just want to remember with functional neuroimaging, it provides the researchers with information about the parts of the brain that are active when people are doing specific tasks. So it could be either speaking, looking at a picture, and the brain will light up what area of the brain they're using. When they try to move their hand, even if they can't physically move their hand, the actual process of thinking to do will let the researchers know what part of the brain are they trying to get that information out of. Helps with memory and thought process. So when they show, words or pictures, where are those images? Where are they trying to pull up that information? So it lets us know a lot about how the brain works. So it's pretty awesome. So these non-invasive techniques, coupled with tests of cognitive processing, have shown quite convincingly that age-related brain changes are responsible for age-related declines in cognition and behavior. So it's putting the science behind the observation of actual, interviewing, like we think of those theorists, and we can see the physical decline. Now we can actually have scientific proof through the imagery. So this is an example of that structural neuroimaging. This is a MRI of a stroke, and where you can see in the red is where that lesion is, where that bleed is. So, and that is an example of a structural imaging. Other physiological changes occur, especially in the cardiovascular and respiratory systems. The problems increase with age. The incidence of cardiovascular diseases increases dramatically with age and is higher among African Americans. However, the overall death rates from these diseases have been declining over recent decades, right? Because of better medical care, better advances in technology, better medicines, all that together. But the death rate for some ethnic groups remains much higher because of those things we talked about earlier. Poor preventive health care, lack of financial resources to support a healthy lifestyle, lack of medical access. As people grow older, their chances of having a stroke increases. So a stroke is considered, it's considered a stroke or a cerebral vascular accident, a CVA. And it's caused by an interruption of blood flow in the brain due to blockage or hemorrhage in a cerebral artery. Blockages of an artery may be caused by clots or by deposits of fatty substances due to the disease atherosclerosis. Hemorrhages, which are considered brain bleeds, are caused by ruptures of the artery, which would be an aneurysm. CVAs are the leading cause of disability. Because you imagine, right? Speech, physical, some can't even move, some can't talk, some can't move one side of their body. And they're the fourth leading cause of death in the United States. Research indicates that quick intervention and aggressive rehab results in better recovery. And evidence of brain damage may be attained from the structural, remember we talked structural, shows us the actual anatomical changes, neuroimaging. And we saw that in the last picture. So I work with strokes, I've worked with strokes my whole career. So Memorial is considered a stroke certified hospital. So we have specific timelines on how quickly we needed to treat the patient. So then we have like from phone call to door. So CT within 20 minutes of hitting the inside the hospital. Rehab has to be seen. Somebody from rehab has to have an evaluation within 24 hours. If it is an embolic stroke, a clot stroke, they can be given a medicine called TPA if we know the timing of the stroke, which would be within 3 to 4 hours of symptoms. Then they can get this medicine to break up the clot. So all this is very important. So all this new technology and hospital system has led to greater reduction in adverse effects of stroke and better rehab. Also, older adults often experience what's called a mini stroke or a transient ischemic attack, or TIAs, which involves interruption of blood flow to the brain and are often early warning signs of stroke. So a TIA, if you've had a TIA, it is one of the most predictive risk factors of having a stroke. So it's like a warning sign. It's definitely something to give you a wake up call to change your diet, get treated so that you don't have the big stroke. A single large CVA may produce serious cognitive impairments, such as loss of the ability to speak, physical problems. You may be flaccid all on one side, not an ability to move one side of the limb. And with strokes, it affects the opposite side of your brain. So if you have a right CVA, it affects the left side. Recovery from a single stroke depends on many factors, right? The extent, the type of loss, how quickly you got medical attention. If you've had previous strokes, right? And just remember, the biggest thing you can take away from CVA is if you're having any symptoms, you need to get into the hospital. So what they consider symptoms is if you follow that FAST acronym, which is you want to act fast. So you want to think that. So face, if your face is drooping, if you have the A stands for arm weakness. So if you have unilateral weakness, one arm is really weak. Speech, S, speech difficulties. And time is critical. Remember I told you about that medicine, that TPA that can be given? So all of that. So you just got to remember fast. So if anything you remember from stroke education, fast. Face drooping, one-sided arm weakness, speech difficulty, and time. You need to act fast with the stroke. So now we're going to talk about other physiological changes. One of those is vascular dementia. So it's a disease caused by numerous small CVAs. Unlike Alzheimer's disease, which we'll discuss later, vascular dementia can have a sudden onset, right? Because they're having all these little mini infarcts, which is infarct is the CVAs. Typical symptoms include hypertension, specific and extensive alterations on an MRI, and a pattern of scores on neuropsychological tests showing some functions intact and others significantly below average. In some cases, vascular dementia has a much faster course than Alzheimer's disease, resulting in death an average 2 to 3 years after onset. In other cases, the disease may progress more slowly with idiosyncratic symptom patterns. So it just depends on how many of those little small CVAs you have. If you have a lot of them, you're going to have much more damage in the brain, right? So you're probably going to die faster. And again, it's diagnosed by structural imaging, right? We remember structural is the picture. So it's going to show us that picture of the bleed or the blockage. Another physiological change is chronic obstructive pulmonary disease, which is called COPD. It's the most common form of incapacitating respiratory disease among older adults. So when it comes to the respiratory system, the decline in maximum lung capacity is the main cause of shortness in breath in later life. So the most common form of this incapacitating respiratory disease among older adults is COPD. It can be extremely debilitating condition and may result in depression, anxiety, and the need to be continually connected to oxygen. So one of the worst feelings you can have is not being able to breathe. I've seen it many times. It's almost like they're drowning. If you think about you're underwater and you can't catch a breath, that's how they feel all the time. And the more they try to catch a breath, the worse it gets. The best thing they can do for COPD is just really teach them how to breathe. Have them have stress, release that anxiety. When you have anxiety, you use more accessory muscles. You don't use your diaphragm. You need to teach them to breathe out longer breaths going out, deeper breaths coming in. The biggest problem is that when they get anxious, they don't blow out enough the bad air, so there's no room to get the good air in. So it's a lot of compensation techniques. Rehab sees them for, and respiratory therapy sees them for teaching them how to breathe. Again, how to use the muscles correctly and conserve energy, how to do activities without utilizing all their breath. We use a term, it's called WOB, work of breathing. What does each activity require you to do? What is the work of breathing? Sometimes just sitting, they have a very high work of breathing. One of the main lung conditions is emphysema, and it causes shortness of breath. In people with emphysema, the air sacs in the lungs, alveoli, are damaged, and over time, the inner walls of the air sacs weaken and rupture. This creates large air spaces instead of many small ones. So they have these large ones that can't contract well. They're thin, so they can't push the air out. Your body needs these small little alveoli because those are the very, very small ones that at the very, very end of your lung to help push that air out. And when you just have one big, large one, it doesn't do an efficient job. So they're very short of breath. With the reduced surface area in the lungs, the amount of oxygen decreases that can reach your bloodstream. And when you exhale, the damaged alveoli don't work properly, and old air becomes trapped, leaving no room for fresh oxygen-rich air to enter. So again, that's why we teach a lot of compensatory techniques of how to get that old air out and get the much fresh air in. So this is just a picture of vascular dementia. I just wanted to show you. You can see in the one part is healthy blood cells, and you can see blood vessels with multiple infarcts. So could you imagine throughout your brain if you had these many little infarcts, and it could affect all the different areas of your brain, creating vast knowledge, cognitive deficits, physical deficits, just depending on where those infarcts are. So this is an MRI of vascular dementia. This would be a structural neuroimaging. So on the left, you can see there's a normal MRI, and on the right is vascular dementia. So you can see those white areas is where the brain is dying, where those areas of blood supply, where those little infarcts are. You can see look how large the ventricles are. So when those ventricles are that large, it's pushing all on that brain matter. So when you're pushing on the brain matter, causes those cells to die and causes the brain not to function correctly. So depending on the areas where it's affected, which this one looks like it's affected throughout the brain, you're going to have cognitive, physical, emotional, all those areas that we learned about the brain being affected. So this is a picture of emphysema, which we talked about. So I wanted to show you what it looked like. So you can see that normal alveoli. See how small the little round alveoli are? So that increased surface area helps push out the bad air. So you can see the damage, how it becomes just one big, and it can't contract. It doesn't have enough small little surface area to do that pumping out. And you can see, remember I told you they're at the very, very end of your lung branches. So that's what has to push out all that bad air. So if you can imagine, if that can't push it out, how that air gets trapped in there. So there's not enough room to breathe in that good air. So a lot of times, even though they've got oxygen, they may be desatting into the 80s because no matter what they do, they cannot get those alveoli to get the bad air out. So sometimes their normal weight might be 85%, but you've really, really got to teach them energy conservation and how to breathe using those lower diaphragm muscles. So now we're going to talk about sensory changes. So growing older brings with it several normative changes in sensory abilities. These changes can affect a person's ability to enjoy life, but in most cases can be adequately compensated for through various types of intervention. So let's look at them. So vision. So changes occur in vision that will affect how we see in later life, right? One is a decrease in the amount of light that passes through the eye. It results in the need for more light to do tasks such as reading. So has your mother ever told you, turn that light on, you're going to ruin your eyes, right? So as you're older, you actually do need more light because your eye actually has changed. As you might suspect, this change is one reason older adults do not do well in the dark. They don't want to drive in the dark, right? Have you ever had a family member say, I don't drive at night? One logical response is to the need for more light would be to increase illumination levels in general. However, this solution does not work in all situations because we also become increasingly sensitive to glare. So they're saying the solution is to increase the light, but also, okay, our lights don't, our eyes don't reflect the glare very well as well. So when you turn on light, you have more glare off of objects. So we're finding the solution can sometimes cause more problems. So you got to strike a balance there. Um, Another structural change would be the ability to see detail and to discriminate different visual patterns, and that's called acuity. So our acuity declines steadily between the ages of 20 and 60, with a more rapid decline thereafter. So again, that loss of acuity is especially noticeable at low light levels. So as we age, so something I think about when I'm treating my older adults is I always have good lights for seeing. It helps with balance and all that, but for seeing and be able to see their environment because they actually have age-related changes in the eye itself. Um, so middle-aged and older adults have difficulty seeing things close up. So have you noticed that as you see older people read, they take their menu and put it really far in front of them? Because as we age, seeing up close starts to deteriorate. So what we consider nearsightedness, or the ability not to see, decreased ability to see far away, that can happen in any age group. But the farsighted, or the decrease in the ability to see close up, is age related, and it's called presbyopia, and that's difficulty in seeing close objects, and that's age related. And it's caused by yellowing of the lens and a stiffening of the muscles around the lens. So it's actually physiological changes in the eye. So that's why a lot of people have those reader glasses, and they sell them at every Rite Aid and Walgreens, right? So think about those age-related structures in vision. It's actually the changes in the eye. So just like you have physiological changes otherwise, other places in the body, the eye actually changes, and there's reasons why older adults won't want to drive at night. They need more light to read, and that they have to hold that menu way out there. Continuing with vision, we're going to go over some of the abnormal structural changes in the eye that can cause diseases. So the ones before were the normative structural changes that everybody experiences. You live long enough, you're going to experience that. But there are also disease processes that are caused by abnormal structural changes, and those are what we're going to go over now. The first one is cataracts. So opaque spots, which are called cataracts, may develop on the lens, which limits the amount of light transmitted. Cataracts are often treated by surgical removal and use of corrective lenses. So I know my grandmother had cataract surgery, and it's very easy outpatient surgery. Second one is a pressure of the fluid of the eye leads to glaucoma. The fluid in the eye may not drain properly, and that causes a very high internal pressure. This condition is called glaucoma, and it can cause internal damage and loss of vision. Glaucoma is a fairly common disease in middle and late adulthood, and is usually treated with eye drops. If you think about it, I don't know if you guys have had it yet, but this is the eye test where they dilate your eyes and they blow a puff of air into your eyes to change the pressure to see how your lens reacts to that pressure to see if you have glaucoma. So if you haven't had that test yet, you'll eventually have it at the eye doctor. Because if caught early, it's really treatable with eye drops, right? Very simple. The second major family of changes in vision results from changes in the retina. So the retina lies approximately 2/3 of the interior of the eye, and it's specialized receptors cells for vision, the rods and cones, and they're all contained in the retina. So they're most densely packed toward the rear, especially at the focal point of vision, and that region is called the macula. So that retina is very, very important in our vision. At the center of the macula is the fovea, where incoming light is focused for maximum acuity, as when one is reading. With increased age, the probability of degeneration of the macula increases. Age-related macular degeneration involves the progressive and irreversible destruction of receptors from any number of causes. So this macular degeneration and disease is the loss of the ability to see details. So for example, reading becomes extremely difficult, and television is often reduced to a blur. Roughly 1 in 5 people over age 75, especially smokers and European American women, have macular degeneration. and makes it the leading cause of functional blindness in older adults. So the chances of you treating, if you're in the medical field, or knowing someone over the age of 75 that has macular degeneration is pretty high. 1 in 5 people. The second age-related retinal disease is a byproduct of diabetes. So remember, we talked a lot about different causes of diabetes, but this is a big one. Diabetes is accompanied by accelerated aging of the arteries. So it makes those arteries become harder, with blindness being one of the more serious side effects. Diabetic retinopathy is a condition that involves fluid retention in the macula. So with that extra fluid, you can get to detachment of the retina, hemorrhage, which is bleeding, and aneurysms. Because it takes many years to develop, diabetic retinopathy is more common among people who develop diabetes early in life. So the earlier you have diabetes, the more likely you're going to get diabetic retinopathy because it's a byproduct. Remember, it's accelerated aging of the artery. So it takes time to age those arteries. So basically you have like a little mini infarct in the back of your eye that causes the retina to that fluid retention in the macula. So those are some of the structural changes, disease processes that can come with aging. So let's go on to our next sense. If you're thinking about aging, besides vision, what's the next thing you think of deteriorating? Hearing, right? So let's talk a little bit about hearing loss. Age-related changes in hearing can interfere with people's ability to communicate with others, right? Hearing loss is one of the well-known normative changes associated with aging. So, like I said, if it's a normative change, that means everyone will eventually get it if you live long enough. Loud noise is the enemy of hearing at any age. So no matter what age you are, so if you're listening to loud noises now, you're wearing those headphones, you may have a higher chance of hearing loss in adulthood. You probably have seen people work in very noisy environments wearing protective gears on their ears so they are not exposed to loud noises over extended periods. But you don't have to be in a loud environment to damage your hearing. Like I said, headphones or earbuds, especially at high volume. Does your phone give you a warning? Listening to high volumes may cause hearing loss, right? It's a preemptive way to prevent this damage. It is especially easy to cause hearing loss with headphones or earbuds if you wear them while exercising. The increased blood flow to the ear during exercise makes hearing receptors more vulnerable to damage. The cumulative effects of noise and normative accelerated changes create the most common age-related hearing problem, and that's reduced sensitivity to high-pitched tones or presbycusis, which occurs earlier and more severely than the loss of sensitivity to low-pitched tones. And research has indicated that by most people's late 70s, roughly half of older adults have presbycusis. I'm going to tell you a story. So for me, I actually have started having hearing loss when I was in my 30s. And it took me about 10 years to get diagnosed for someone to actually take me serious. But it did. It started with high-pitched noises. There are noises I don't even hear. In my left ear, I cannot hear. I have 70% hearing. I have like 3 or 4 pitches that I don't hear at all. You may not even notice, but I do wear hearing aids that have helped substantially. They think that mine is a genetic factor, that I probably inherited it. Who knows? Maybe I went to a loud concert. Did I wear headphones too much? So definitely started in my 30s. So the great thing is there's tons of advancement. My hearing aids are awesome. I can connect my phone to them. I can listen to any Bluetooth through them. I can talk through my phone through them. I can have music all the time. But definitely has made me have compensatory strategies. I have to read lips. I can't hear whispering. Different inflections, accents are hard to hear. Not that I don't hear all the sounds, it's that I don't understand them. I don't hear some of the pitches. Consonants are high pitched. I don't hear bed alarms at hospitals. So all those things take in consideration. So It can happen at any age, but that's that type of high-pitched tones. And loss of hearing in later in life may cause numerous adverse emotional reactions, such as loss of independence, social isolation, irritation, paranoia, and depression. So while hearing loss may not directly affect the older adult's self-concept or emotion, it may negatively affect how they feel about interpersonal communication. So what they found is that people that can't hear, and I can attest to this, if you don't want to be in social situations because it's very hard, background noise, you can't hear conversations, you can't be part of conversations, and it becomes really stressful to be around new people that don't know, that you can't hear well, that be put on the spot. So many older adults, what they do is they isolate themselves. And the more they isolate themselves, the less activity they're getting to their brain and the more cognitive and memory issues they have. So one of the best things you can do for hearing loss is to not get it fixed, but get devices that help, hearing aids, learning, communicative way to communicate, but don't isolate yourself because that's what causes those problems. The more you isolate yourself, the less you're going to activate those areas of the brain. So this graph just shows hearing loss in adults. Hearing loss occurs in all adults, but it's greatest for high-pitched tones. So remember, that's the biggest thing. And those are usually those consonants. And greater for men than for women. So the highest tone in a piano is 4186 hertzes, and normal humming ranges between 27 and 20,000. So it's usually gradual at first, but accelerates during middle age, and you can see the pattern clearly with the hertz. So if you actually look at my hearing exam, so in my right ear, I can hear the first sound, the second sound, and then I hear nothing. I actually probably have a hearing in my right ear of like a 70, 80-year-old. So it's almost like my hearing loss is accelerated. So it would, if you looked at my testing, you would think I was 70 years old when I was like 35. So it's unique to see that. So if you've ever had a hearing test where they put the headphones over you, and then you have to say the sounds and the words, I'll let you know for me, when they cover their mouth and they say the sounds to the earphones, I cannot understand them. I have to have see your mouth move and connect the sounds with the mouth. So as you treating patients that have hearing loss or older population, just be aware that they're looking at that. They're looking at those physical cues, the way that you pronounce your words. So reading lips. So talk slow. Let them see you talk and just respect that. That's probably going to be an occurrence in your older population if you're treating them. Now we're going to go over some health issues that affect older and late adults. So half of the United States have a chronic health condition. So that's insane, right? Half of the United States adults have a chronic health condition. Some of the most common are diabetes, cancer, and arthritis. So you can imagine the need for increased health care, public health, all that stuff, treating the chronic health condition. So let's start by going over diabetes a little bit. Diabetes mellitus. The disease diabetes occurs when the pancreas produces insufficient insulin. So the primary characteristics of diabetes is above normal sugar, which is glucose. So you take that glucose, when they prick your finger and they measure it. So that's in the blood, and urine caused by problems in metabolizing carbohydrates. People with diabetes can go into a coma if the level of sugars get too high. So I've seen the normal, 150, depending on your fasting and stuff. I've seen patients that have been in the 1400s. Insane, right? Some of them, I saw a patient in the 1400s walking. It's amazing. He should have been in a coma. And I've also seen them in a diabetic coma. Your body cannot metabolize it fast enough, and you may lapse into unconsciousness. There are 3 groups of older adults with diabetes. So you can either develop diabetes as a child, and that's type 1 diabetes. Remember, those people are more likely to have those diabetic retinopathy. You can get it as an adolescent or young adults. Those who develop diabetes in late middle age and and typically develop cardiovascular problems, and those who develop diabetes in late life usually show mild problems. So really late life, like 60, 70, right? They're not gonna have a lifetime of all the changes that diabetes causes. So that last group I talked about is a majority of older adults with diabetes mellitus. In adults, is often associated with obesity and is usually diagnosed during other medical procedures, such as eye examinations, right? That diabetic retinopathy, they start doing that pretty young, and they diagnose that first, and then they let leading them to get medical treatment for diabetes. Diabetes is more common among older adults and members of minority groups. So why do you think that? So the chronic effects of increased glucose levels may result in serious complications, including nerve damage, diabetic retinopathy, kidney disorders, stroke, cognitive dysfunctions, damage to the coronary arteries, skin problems, and poor circulation in the arms and legs, which may lead to gangrene and eventually amputation. So if we think about the causes, so we can understand why maybe some members of minority groups get it more. Maybe they are in a lower socioeconomic class and they don't have access to medical care. Maybe it's cultural because they have a diet that is high in fats and high in sugar. So maybe it's cultural. Maybe it's just the way they've lived, their environment. So it's not all, but some of those factors may contribute to that. So although diabetes can't be cured, it can be managed effectively through a low carbohydrate and low caloric diet, exercise, proper care of skin, gums, teeth, and feet, and medication, which would be insulin. So many people that just change their diet and exercise can avoid having insulin. For older adults, it is important to address potential memory difficulties with daily testing and management regimens. Because if their sugar is too high, right, they can start getting those effects and have mental effects, and eventually lead to a coma. So education about diabetes is included in Medicare coverage, so that making it easier for older adults to learn about and how to manage the condition, right? Because especially Kern County has a huge population of patients diagnosed with diabetes. So think about Kern County, think about the population, and then think about why that may be. And like I told you earlier in the semester, we've seen such an increase in diabetes, and especially in 30 and 40-year-olds. So we're seeing a lot of these things that would happen in older adults happening in that middle and early adulthood. So it's definitely a huge problem in Kern County. So the second leading cause of death in the United States is cancer. 1 in 2 American men and 1 in 3 American women will develop cancer. That is insane statistics. Half of American men and a third of American women will develop cancer. So you or someone you know has probably had cancer. So what causes that? The risk of getting cancer increases markedly with age. The research in molecular biology and microbiology increasingly points to genetic factors underlying cancer, so likely in a combination with environmental factors. So they're thinking about genetic factors. Maybe you've heard of the breast cancer gene or the prostate cancer gene, and then factored with environmental influence, causing a greater chance of cancers. There's been controversy of if you get tested for this gene, will insurances cover you? People tested for the breast cancer gene, many of them not only get breast cancer, get ovarian cancer. So I don't know if you heard in the news a few years ago, Angelina Jolie actually tested positive for this. Her mother died of cancer early in her 40s. So she actually had a bilateral mastectomy and her ovaries removed as a preemptive move. What do you guys think about that? If you had the gene, would you do that? Would you have a mastectomy, take your breasts, remove your ovaries so you wouldn't get cancer? especially with these factors, right? It's a decision to be made. So screening for cancer, like I said, remains controversial. And again, many cancers are preventable. So we think about those genetics, but also, smoking. We know smoking can cause lung cancer. We know sun exposure to ultraviolet rays can cause skin cancer. We know an unhealthy diet can increase your chances of cancer. So just by stopping smoking, limiting your sun exposure, and eating a healthy diet can definitely decrease your chances of getting cancer. So other health issues is sleeping and eating right. So we know that two key factors in staying healthy are getting enough good sleep and eating a healthy diet. Older adults report taking longer to fall asleep and feeling more negative after a night of inadequate sleep than younger adults. Compared with younger adults, older adults report that it takes roughly twice as long to fall asleep, that they get less sleep on an average night, and that they feel more negative effects following a night with little sleep. Some of these problems are due to other mental or physical health problems. Sleep problems can disrupt a person's circadian rhythm or sleep-wake cycle. Remember we talked about that earlier in the semester, that you need to get in that deep REM sleep to repair your body. So if you never get into that deep REM and complete the cycle, you're never really getting restful sleep. If you get disruptions in that circadian rhythm, it can cause problems with attention and memory. Research shows that interventions such as properly timed exposure to bright light are effective in correcting the circadian rhythm sleepovers. Nutrition. So most adults do not require vitamin or mineral supplements as long as they are eating a well-balanced diet. Even though the body metabolism we say declines with age, older adults need to consume the same amounts of proteins and carbohydrates as young adults because of the changes in how readily the body extracts the nutrients from these substances. So basically, an older adult needs to eat the same amount because the body doesn't efficiently take the nutrients out as well. So it needs to maintain that amount so it has more of the nutrients, because our body, as the older adult body, doesn't absorb as many nutrients. So if you decrease the calories, you're going to decrease the nutrients as well. Okay, so we really see these nutrition issues, especially in nursing homes. So because they're typically in poor health, residents of nursing homes and frail older adults are especially prone to malnutrition or deficiencies of such nutrients as vitamin B12 and folic acid, unless their diets are closely monitored. I would see this all the time in nursing homes. Like I said earlier, like when we talk about healing, your body needs proteins. That's what heals. So like if you've had any kind of injury or disease process, it needs those proteins. You got to keep up the nutrition to heal. So you think about that older adult, later adult, they have a lot of injuries, they have a lot of disease process going on. So if they don't keep up that nutrition, they're not going to repair, and they already don't repair as well. So nutrition plays a huge factor in cognitive, mental, physical health. So let's revisit that My Plate. Remember that healthy plate we saw in earlier lectures? So this is a My Plate for older adults. So a good nutritional guide for older adults is that My Plate, right? So this figure is based on the U.S. Department of Agriculture's guidelines. It takes into account the changes that occur with age. Any changes from the My Plate diagram we saw for the older adult population? So look at this and look at the old one. What do you see changes? One of the most important thing for older adults is proper nutrition, especially protein and vitamin, right? Like I talked about, for tissues to heal and repair themselves and support immunity. So you can see on this plate how half of it is fruits and vegetables for all those vitamins and minerals, right? They need all that. And then you can see that protein. So take a look at the other My Plate and see if you can see the differences. So now let's transition to the cognitive processes of older late adults. What changes occur in information processing as people age? How do these changes relate to everyday life? What changes occur in memory with age? What can be done to remediate these changes? What are creativity and wisdom? How do they relate to change? Very important because that's going to be in your discussion group this week. So, innovations and discoveries in neuroscience have resulted in major advances in our understanding of how people process information across their lifespan, right? The most common approach involves using task-related neuroimaging techniques, such as an fMRI, a functional MRI, to measure brain activity while the person is performing the cognitive task. So we can learn the best ways to stimulate the brain to help with that cognitive process. So let's take a look at how we process information. What makes a difference in how we process information as a later adult and an early adult? So remember those teenagers and that early adult, how their information, their speed of information was much quicker? Do you think that's happening in the later adult? So hundreds of studies of psychomotor speed point to the same conclusion. People slow down as they get older, which we could predict that. The slowing with age finding is so well documented that many researchers accept that it is the only universal behavioral change in aging discovered so far. So basically they're saying that only thing that they can behaviorally, that they can prove scientifically without a shadow of a doubt, is that psychomotor speed slows down as you get older. It's the most concrete behavioral change with age. The most important reason reaction times slow down is that older adults take longer to decide that they need to respond, especially when the situation involves ambiguous information. So when it's not clear what is being asked or the outcome. Although response slowing is inevitable, the amount of the decline can be reduced if older adults are allowed to practice making quick responses or if they are experienced in the task. So repetitive activity, experiencing the task actually helps them predict, so it improves that speed. Because psychomotor slowing is a universal phenomenon, no matter where you are in the world, researchers have argued that it may explain a great deal of the age difference in cognition. Psychomotor slowing is a good predictor of cognitive performance, but there's a catch. The prediction is best when the task requires little effort. So it can't be a complex task. It has to be an easy task that most people can do with little effort. And that will be able to help predict other cognitive deficits. If the task requires more effort and is more difficult, then working memory, which we'll discuss later, and that's the memory that you use every day, is a better predictor of performance. Also, they found exercise can mediate or help the effects of normative aging on cognitive slowing. Neuroscience has shed light on the brain changes that may underline the decline in psychomotor speed. So with that study of all those studies they have with that new imaging, they found that age-related declines in brain of white matter, which is white matter helps with the neural transmission, so you're getting that information across the areas, in turn has been associated with measures of processing speed and other things. So it makes sense, right? So now they can actually support their theory because they can see the imaging and they can see the decline in white matter, and white matter is the processing of information. So that's the transmission, is where that axon goes across. So they actually see the decline in white matter, so then that supports that behavior of slower speeds. So the question they asked them, because of this, do you think older adults should be allowed to have driver's license? All right, let's ponder that till the next slide. So this graph is showing motor vehicle traffic fatalities rates by age group. So, and it's per 100,000 of licensed drivers by their age group. So research documenting age-related changes in attention, psychomotor speed, vision, and hearing has sparked considerable controversy concerning whether older adults should be allowed to drive. So you can see in this figure that although the fatality rate for older drivers over age 75 has declined, it is still higher than for middle-aged adults. So the question is, when is it too old to drive? What do you guys think? Should there be an age cutoff for driving, or should this be individualized? Because individual differences in age-related changes are large, experts have agreed that decisions about whether at-risk drivers should be allowed to continue driving must be based on performance measures rather than age or medical diagnosis alone. Because they're very varying physical and behavioral of 80-year-olds, right? There's a big, large discrepancy of what not every 80-year-old looks the same. So one approach measures the useful field of view, which is UFOV. So they could take the do this test to see if a driver is safe to drive. So what they do is the area from which one can extract visual information in a single glance without turning one's head or moving one's eyes, which can easily be assessed via a desktop computer. There's another version that can be used during normal driving, and it has also been developed. So what you're thinking about is that peripheral vision. By just moving your eyes, can you look and see something, an object come in your path? So you don't hit that pedestrian, hit that child running out to get the ball, right? So it can mean the difference between having an accident and avoiding one. So the UFOV, Useful Field of View test, simulates driving in that it demands quick processing of information, simultaneous monitoring of central and peripheral stimuli, and the extraction of relevant target stimuli from irrelevant background information while performing a task. So basically, you can see that child even run out and ignore the parked car, or ignore the the buildings, the people walking on the sidewalk, that you can see the imaging behind and point out the moving dangerous object. People can be trained to improve the cognitive process that underline their UFOV. So even if they find problems, they can improve. Another way is the American Automobile Association Foundation for Traffic Safety provides the AA Roadwise Review Online, and it's a tool to help seniors drive safely longer. The Roadwise Review is a screening tool developed by the Transportation Safety Researchers and is validated and researched, so it has validated so you can trust its outcomes. It's administered online, and it has 8 key functional areas: leg strength, general mobility, head and neck flexibility, high contrast visual acuity, low visual acuity, working memory, visualization of missing information, visual search, and visual information processing speed. So drivers with a significant loss in the functional capacities are 2 to 5 times more likely to cause a motor vehicle crash than drivers without such a loss. So looking and seeing what this measures, can you predict from what we have learned thus far what age group would score the best, and what areas do you think older adults would score low in, and why? So now let's move on to working memory. Working memory involves the process and structures involved in holding information in the mind and simultaneously using it to solve a problem, make a decision, perform some function, or learn new information. Working memory refers to many similar short-term holding and computational processes related to a wide range of cognitive skills and knowledge domains. So if you want to think about working memory, it's that memory that lets you remember your password login, appointments for next week. It's that short-term immediate memory that you have to work with daily and still do other things. You can just retain it in that working memory. You can pull it up quickly. Because working memory has a relatively small capacity and it deals with information that is being used at the moment, it's kind of like your mental scratch pad. So it's what you need to do this week, what you need to do today, and unless we use it and keep the information active by maybe rehearsal or tell somebody else or pass along to the long-term storage or the page we are using will be filled up quickly. So you're thinking of that little mental pad. So if we say, oh, I gotta, get study for my tests on Thursday night and it's Monday, and I never look at that again, then I have my little one little tiny post-it note. If I never use it, remind myself, put it in my phone, put it in my calendar, I may forget it completely because something else is going to fill up that post-it. If I don't rehearse it, remind myself, and then put it in my long-term memory, I may forget it. So you got to think of it. Think of it like a little post-it in your brain, and that's your working memory. And if you don't keep going over it, something is going to take its place because you can only have so much information on it. So working memory generally declines with age, which explains the age-related differences in cognitive performance on tasks that are difficult and demand considerable effort and resources. So taken together, working memory and psychomotor speed provide a powerful set of explanatory constructs for predicting cognition, right? So if you have slower speed and you have a poor working memory, you're probably going to have decline in cognitive function, right? You can't pull out information quickly, and you can't process things quickly. So you can't take in new information and process it, and you can't remember old information and process it quick. Why do these age differences occur? It turns out that older adults activate the prefrontal area of their brains. So remember, that's that area behind the forehead, more than younger adults during working memory tasks, and also exhausts their resources sooner. However, research also shows that older adults can be trained to increase their working memory, which is reflected in more efficient brain processing. So how do you think you could train your working memory? Well, let's look at that. So now we're going to divide memory into two types: explicit memory and implicit memory. Explicit memory is deliberate and unconscious, remembering of information learned and remembered at a specific time. We'll further divide it into episodic memory, which is the general class of memory having to do with the conscious recollection of information from a specific time or event, and semantic memory, the general class of memory concerning the remembering of meaning of words or concepts not tied to a specific time or event. More research has focused on explicit memory, and it is here where consistent age-related differences are usually observed. One test of episodic memory recall. Older adults emit more information, include more intrusions, and repeat more previously recalled items. These age differences have been well documented, are large, and are not reliably lowered by a small presentation or by cues or reminders given during recall. On recognition tests, age differences are smaller, but still present. Older adults also tend to be less efficient and spontaneously using memory strategies to help themselves remember. But they can learn to use such strategies effectively. So, in contrast, age differences on semantic memory tasks are typically absent in normative aging. So, you don't normally lose your remembering a meaning of words. That's not normal. But are found in persons with dementia. So that's that dementia factor, right? Can't find words, don't know what the meaning are. Making the differences one way to diagnose probable causes of abnormal cognitive aging. So if you're seeing that somatic memory loss, that would be one clue that maybe they have some form of dementia. Neuroimaging studies indicate that when older adults take in information, their prefrontal cortex shows overactivity, indicating that they are attempting to compensate for age-related brain changes. So memory shouldn't be mostly in the frontal cortex, right? It should be back there in the hippocampus and back in the other parts of the brain. When older adults retrieve information, neuroimaging studies show age-related differences in how the prefrontal cortex and hippocampus work together. This research also indicates age-related compensatory brain activity in older adults for retrieval. Specifically, younger adults have more extensive neural network connections, right, in the parietal and frontal regions involved in retrieval than do older adults. So they can retrieve their memory faster and they have more connections. However, older adults show higher levels of brain activity more generally in these regions, indicating a likely compensatory strategy for less extensive networks. So they don't have as many connections, so you see a lot more areas of the brain trying to compensate to recall these memories. Overall, this data supports the view that older adults process information in their brains different than younger adults. So these differences in part represent attempts at working around or compensation. So you want to think of, when you think of explicit memory and that stuff, there's a lot of compensation going on. Episodic is more normal age related, and that semantic is more related to like dementia type changes. Implicit memory is considered the unconscious remembering of information learned at some earlier time. Implicit memory is much like getting into a routine. We do things from memory, but we do not think about them, right? That muscle memory, your body just remembers. It's unconscious, right? You get on a bike, you know how to ride. You just remember. Your body has that innate memory. Whether age differences in implicit memory are observed depends on the specific kind of implicit memory task in question. So I use a lot of that in my therapy. So I may tell somebody, move their arm, let's do 10 reps. That doesn't work. But if I tell them to comb their hair, they just may remember it, maybe an implicit memory. So it's a different area of the brain. So we try to utilize that and restoring and compensating some of the loss of that explicit memory. So as everybody can recognize, this is Jeopardy. And remember when I said that semantic memory tasks are not age related. They are not normal changes in memory. So they found older adults perform as well as younger adults at these semantic memory tasks, like the TV show you see here, Jeopardy, involving remembering facts or words. So to review, what types of memory changes in older adults? So remember, they perform worse on tests of episodic memory. Age differences are smaller, but still present on recognition tests, and that semantic memory difficulties usually only are seen in people with dementia. And that neuroscience research shows that structural changes in the brain underlie changes in memory. So those functional MRIs can actually show now the changes in the brain match the behavior changes. So forgetfulness is a major stereotype of older and late adults, right? Is forgetfulness always indicative of something worse? Because people are concerned that memory failure may reflect disease, identifying true cases of memory impairing disease is extremely important. Once a serious problem is suspected, the next step is to obtain a thorough examination. This should include a complete physical and neurological examination and a complete battery of neuropsychological tests. They also may help identify the nature and extent of the underlying problem and provide information about what steps, if any, can be taken to alleviate the difficulties. So they need to determine whether memory problems are interfering with everyday function. And again, need to do that thorough examination. Neuroimaging can also help sort out the specific type of problem or disease the individual may be experiencing. The most important point to keep in mind is that there is no magic number of times a person must forget something before it becomes a matter for concern. I at times think, I forget a lot. Does that mean that I'm having, memory issues? Do I have early signs of stuff? So all these things we have to consider. The big picture, the whole picture, can help diagnose and discriminate between just normal forgetfulness or disease process. Indeed, many memory impairing diseases progress slowly, and poor memory performance may only be noticed gradually over an extended period of time. The best course is to be examined. Only with complete and thorough testing can those concerns be checked inappropriately, so they can rule out all the other things. So sometimes people who are experiencing normal age-related memory changes need extra help because of the high memory demands they face. And at other times, people need help because the memory changes they're experiencing are greater than normal. So just remember that even though you may be experiencing some of these memory problems, that you can definitely have strategies to help you retain them. It's not a lost cause. So this figure shows some of those strategies and explains a little bit how they can be applied to different types of memory issues. So if you look at this, this is the EI-EIO model of memory, and it helps categorize different types of memory and their aids. So it was developed by Camp and colleagues, and this framework is to handle both situations. The EI-EIO framework combines two types of memory, explicit and implicit. The framework also includes two types of memory aids. So external aids are aids that rely on environmental resources, such as notebooks and calendars. So internal aids are memory aids that rely on mental process, such as imagery. The aha experience that comes with suddenly remembering something, as in, oh, now I remember, is the O that follows these E's and I's. As you can see in the figure above, the EI-EIO framework allows different types of memories to combine with different types of memory aids, and it provides a broad range of intervention options to help you remember. So you're probably most familiar with the explicit external and explicit internal types of memory aids. Explicit internal aids, such as rehearsal, helps people remember phone numbers. Explicit external aids are used when information needs to be better organized and remembered, such as using a smartphone to remember appointments. Implicit internal aids represent nearly effortless learning, such as the association between the color of a particular wing of the apartment building one lives in and the fact that one's residence is there. So implicit external aids, such as icons representing time of day and the number of pills to take, help older adults remember their medication. So in general, explicit external interventions are most frequently used to remediate the kinds of memory problems that adults face. So explicit external, the most common intervention used for memory problems of older adults. Probably because these methods are easy to use and widely available, right? For example, virtually everyone owns a smartphone or an address book, which they can store addresses and phone numbers, right? So that's that explicit external, right? Appointment book, grocery list. Ensuring that older adults take the proper medication at the proper time is probably best solved by an explicit external intervention, right? That pill box with the proper, that is divided into compartments. Have you seen those? Corresponding to the days and weeks and different times of the day. So that shows them that they know they remember. If it's empty, they took their medicine. And it's easy to follow. Everybody knows what M stands for. It's Monday, right? So research has shown that it's been the easiest way and with the fewest medication errors. Nursing homes and hospitals also use explicit external interventions, such as bulletin boards with the date and weather conditions and activity charts to help residents keep in touch with current events. So if you've looked in the hospitals, we call them the whiteboard at the hospital, and it'll have the date, the day of the week, the date, your nurse, phone numbers on there. We write as therapy. We always write what the patient is safely able to do with nursing, but it allows that patient to have constant reminder where they are, what day it is, what time of day it is, who's seeing them, their doctor's name. So it's definitely an external type of memory aid. Can you guys think of any other examples in your own life or family's life that would fit into these categories? So just remember that explicit external interventions are used most frequently for normal aging memory problems, and they help older adults maintain their independence. Do you remember from the last slide what that was? The example they use is the pill box, right? Monday through Sunday, and with the pills for each day. It could be morning and night, and they know if it's taken away, the box is empty, they've taken it. But universally, everybody knows what that stands for. So just remember that. Explicit external indentation is the most common, frequently, as used most frequently for normal aging memory problems. So like I said earlier, we're going to go over creativity and wisdom. And this is important because this is what your discussion topic is with you. So we're going to ask, do only young people display creativity? Who do you think is more creative? 20-year-old or 70-year-old? Let's explore. So, we want to think of two additional aspects of cognition that have been examined for age-related disorders, and they're creativity and wisdom. So, there's definitely stereotypes associated, right? So, when you think of creativity, you assume it's to be a function of young, old people, mostly young adults, right? Whereas we think of wisdom is assumed to be the province of older adults. Do you think these stereotypes hold true? So what makes a person creative? Got to understand it before you can see if who displays the most, right? Is it exceptional productivity? Does creativity mean having a career marked by precocity and longevity? Researchers define creativity in adults as the ability to produce work that is novel, high in demand, and task appropriate. Creative output in terms of the number of creative ideas a person has or the major contribution a person makes varies across the adult lifespan and across disciplines. When considered as a function of age, the overall number of creative contributions a person has tends to increase through the 30s, right? That's when you're in your peak of your career, right? Peaking in the early 40s, maybe that's where you're at the pinnacle of your career, but then begins to decline thereafter. Why do you think that? Well, the age-related decline does not mean that people stop being creative. It just means that they produce fewer creative ideas than when they were younger. So they're still creative, they're just not as creative. In fact, the age at which people made major creative contributions, such as research that resulted in winning the Nobel Prize, increased throughout the 20th century. In short, creativity never stops. So they may say that, so that's just saying that you can look at that 65-year-old. They may not have 100 ideas like a 20-year-old, but they might have 10 good ones. And because they still are creating and thinking, those 10 good ones, maybe one of them is a Nobel Peace Prize. You don't have to have 100 good ideas, you just have to have one, right? So they're still being creative, just not as many ideas. But doesn't mean that their ideas don't have validity and are creative. Neuroimaging research is supporting previous research that a person's most innovative contribution tends to happen most often during 30s or 40s, as well as it shows that a creative person's brain works differently. That would be a neat MRI to see, right? See what lights up on your brain when you're creating. This research shows that white matter brain structures, so that's that processing brain matter, that connects distant brain regions to coordinate the cognitive control of information among them are related to creativity and are more apparent in creative persons. So they're basically saying they have more white matter in creative people, and that means they have more information processing. This research supports the belief that creativity involves connecting disparate ideas in new ways, as different areas of the brain are responsible for processing different kinds of information. Because white matter tends to change with age, this finding also suggests that there are underlying brain maturation reasons for which innovative thinking tends to occur most often during late young adulthood and early middle age. So let's move on to wisdom. Based on years of research using in-depth think aloud interviews with young, middle-aged, and older adults about normal and unusual problems that face people, Baltz and colleagues were able to describe 4 characteristics of wisdom. So they decided that wisdom deals with important or difficult matters of life and the human condition. Wisdom is truly superior knowledge, judgment, and advice. Wisdom is knowledge with extraordinary scope, depth, and balance that is applicable to specific situations. Wisdom, when used, is well intended and combines mind and virtue, which is character. Research has used this framework to discover that people who are wise are experts in the basic issues in life. So they found that wise people know a great deal about how to conduct life, right? How to interpret life events and what life means. It refers to this as strength, knowledge, and understanding learned only by living through the earlier stages of life. So with that said, research studies have indicated that contrary to what people expect, there is no association between age and wisdom. As envisioned by Baltz and colleagues, whether a person is wise depends on whether she has extensive life experiences with the type of problems given and has a requisite cognitive abilities and personality. So you can have an older person who's 70 who has very limited life experiences, maybe lived in the same town, did the same job, or you could have a 25-year-old who's already traveled the world, had a lot of life experiences, lots of subjected to lots of experience in a certain area that is wiser in that area. So it's very dependent on experience and knowledge and processing of certain subject matter. So wisdom could be related to that crystallized intelligence. Remember that Erickson's theory, knowledge that builds over time and through experience. So, what specific factors help someone become wise? Baltz in 1993 identified three factors. So, general person's conditions, such as their mental ability, they have to have the mental capacity to learn. Specific expertise conditions, such as mentoring or practicing. And facilitative life context, such as education or leadership experience. Personal growth during adulthood, reflecting Erickson's concepts of generativity and integrity, also help foster the process, as do facing and dealing with life crises. It allows you the experience to have those life crises and then to gain knowledge and wisdom depending on the results, right? Whether it's good or bad, you're always gaining information to help with the next decision. But all of these factors take time. Thus, although growing old is no guarantee of wisdom, it does provide the time that, if used well, creates a supportive context for developing wisdom. Interestingly, peer ratings of wisdom are better indicators of wisdom than our self ratings, right? Do you think you're wiser than maybe your friend thinks you are? It appears that people are better at recognizing wisdom in others than they are in themselves. So let's review. What helps a person become wise? Can you think about what I just said? General personal attributes, right? Such as mental ability. You have to have the framework to be able to take in that knowledge. Specific expertise, such as mentoring, being an apprentice, learning from, someone more experienced. And facilitative life context, such as education or leadership experience. And time. You just have to have time to have had these experiences. So let's move on to mental health and intervention. Let's look at, how does depression in older adults differ from depression in younger adults? What do you think causes it? How is it diagnosed and treated? We're going to go over Alzheimer's disease, how it's diagnosed and managed, what causes it, what other common forms of dementia occurs in adults. Let me pose this question to you. True or false? Most older adults suffer from depression or dementia. What do you think? Actually, it's false. Only a minority have mental problems, and most are treated with therapy. Many people mistakenly believe that nearly all older adults have depression, dementia, or both. When they observe older adults behaving in these ways, they take no action because they believe that nothing can be done. We'll review and show that such beliefs are wrong, that only a minority of older adults have mental health problems, and most of these problems do respond to therapy. Sometimes these problems manifest themselves differently in younger and older adults, so we need to look at that as well. Remember, accurate diagnosis is essential. Most people are going to feel down or sad from time to time, perhaps in reaction to a problem at work or in a relationship. But that doesn't mean that most people are depressed. So, how is depression diagnosed and treated? Are there age-related differences in the symptoms? First, let's dispense with the myth, right? Contrary to the popular belief for healthy people, the rate of severe depression declines from young adulthood to old age. So remember that. It declines as you get older. So like I said, rate of severe depression actually decreases with age. Average age of onset is in the early 30s. Depression in later life is usually diagnosed on the basis of two clusters of symptoms, and they must be present for at least 2 weeks: feelings and physical changes. But whereas younger people are likely to label these feelings directly as feeling depressed, older adults may refer to them as feeling helpless, or in terms of physical health, such as feeling tired. Older adults are also more likely than younger people to appear apathetic and expressionless, that flat affect. They just don't care. They confine themselves to bed, to neglect themselves, and to make derogatory statements about themselves. So it's that feeling of dysphoria is usually the most prominent symptom. So you got to remember that's the feeling of uselessness or feeling tired. And that is more likely a sign of depression. Whereas in younger adults, that's that feeling depressed. So this graph shows the 12-month prevalence of depression among all U.S. ages by adults. So you can see how it decreases as you get older. 18 to 25 is the highest, 26 to 49 next, and then you can see a substantial decrease in 50 plus. So what are some of the physical changes of depression? It includes loss of appetite, insomnia, and trouble breathing. But it must not be confused with normal age-related physical changes, and it must rule out other possible causes of symptoms. So remember, a good physical and psychological exam is required. Remember, in young people, these symptoms usually indicate an underlying psychological problem, but in older adults, they may simply reflect normal age-related changes. Thus, older adults' physical symptoms of depression must be evaluated carefully. Memory problems are also a common long-term feature of depression in older adults. An important step in diagnosis is ruling out other possible causes, such as neurological disorders, medication side effects, metabolic conditions, and substance abuse. For many minorities, immigration status and degree of acculturation and assimilation matter. Finally, true clinical depression significantly impairs daily life. So if they're not getting out of bed, they're not dressing, shower, that could be a sign of clinical depression. There are two main ideas about the cause of depression. One focuses on biological and physiological processes, particularly on the imbalances of specific neurotransmitters, genetic predisposition, and brain changes. Research indicates that the most likely cause of severe depression in later life is imbalance in neurotransmitters such as serotonin and the action of brain-derived neurotrophic factor. This general view underlies current approaches to drug therapies. So that's where you would be when you're taking drug therapies. They're acting on those neurotransmitters. So all those antidepressants are in the biological, physiological process of the imbalance in neurotransmitters. The second view focuses on psychosocial factors such as loss and internal belief systems. So an internal belief system is what one tells oneself about why certain things are happening. So it's how a person interprets a loss, rather than the event itself that causes depression. In this approach, internal beliefs are emphasized as the cause of depression. For example, experiencing an unpredictable and uncontrollable event, such as maybe the death of your spouse, it can cause depression if you believe it happened because you are a bad person. It doesn't make sense, but it's your own belief about yourself. People who are depressed tend to believe that they are personally responsible for all the bad things that happen to them, that they're being punished, that things are unlikely to get better, and that their whole life is in shambles. So can you imagine if that's your internal belief? How do you get yourself out of that? Because you yourself are telling yourself how bad you are, how bad the situation is, and it's never get better. You definitely need help to help change that outlook. So like I mentioned earlier, medications can alter the balance of certain neurotransmitters. So those are your antidepressants. Medications work by altering the balance of specific neurotransmitters in the brain. For severe cases of depression, medications such as selective serotonin reuptake inhibitors, which are your SSRIs, your heterocyclic antidepressants, your HCAs, and your monoamine oxidase, MAO inhibitors can be administered. SSRIs are the medication of first choice because they have the lowest overall side effects of any antidepressants. SSRIs work by boosting the level of serotonin, which is a neurotransmitter involved in regulating moods. So you can imagine if you increase that levels of neurotransmitter, more getting across, your mood is better and maybe you have less depression. Either as an alternative to medication or better yet, in cognition with it, psychotherapy is a popular approach, right, to treating depression. So if you can fix the medical and you don't give yourself the psychological plans and internal belief system changes, you may not have long-term good effects. So the basic idea in behavior therapy is that depressed people experience too few rewards or reinforcements from their environment. Thus, the goal of the behavior therapy is to increase the good things that happen and minimize the negative things. This is often accomplished by having people increase their activity simply by doing more. The likelihood that something nice will happen is increased. So the more they get out and experience life, the more chances that they're going to have good things happen to them. The less experience they have, more likely things are going to, they just don't have the volume. So if something goes bad, they just think everything goes bad. So they need to increase the activities they have to show that good things can happen too. A second effective approach is cognitive therapy, which is based on the idea that maladaptive beliefs or cognitions about oneself are responsible for depression. From this perspective, those who are depressed view themselves as unworthy and inadequate. The world is insensitive and ungratifying, and the future is bleak and unpromising. In a cognitive therapy session, a person is taught how to recognize these thoughts and to reevaluate the self, the world, and the future more positively, resulting in a change in the underlying belief. So it's changing that internal belief system, right? Teaching them how to think differently about themselves, the environment, and the outcome. Cognitive therapy is the psychotherapy approach of choice for older adults. So that's what you would choose mostly, would be the cognitive therapy over the behavioral. The most important fact to keep in mind about depression is that it is treatable. If depression is suspected, it is a good idea to have the person examined by a mental health professional. A major healthcare problem in the United States is less than 40% of adults of all ages receive minimally adequate treatment for depression. So most of the problem is they're not seeking treatment or they don't have access to treatment. And left untreated, you're going to see those effects of depression. So now we're going to go through dementia and as a result, Alzheimer's disease. So dementia is a symptom, it's not a disease, and it's considered a family of diseases involving serious impairment of behavioral and cognitive functioning. Alzheimer's disease is the most common, so we're going to talk about that. But Alzheimer's isn't dementia, so dementia is just a symptom. Alzheimer's disease affects all socioeconomic, ethnic, and racial groups, and approximately half of all people 85 years of age and older have Alzheimer's. So it's arguably the most serious age-related condition is dementia and the family of those diseases involving serious impairments of behavioral and cognitive functioning. We're going to go and talk a little bit more about Alzheimer's disease, the most common one. So this is a picture of an Alzheimer's patient. You can kind of see that flat look in his eyes, that maybe not knowing, understanding his environment or the woman that's kissing him. Alzheimer's disease involves memory loss to an extent that may include forgetting the names of family members. So, what are the symptoms of Alzheimer's? The key symptoms of Alzheimer's disease are gradual declines in memory, learning, attention, and judgment, confusion as to time and place, difficulties in communicating and finding the right words, decline in personal hygiene and self-care skills, inappropriate social behavior, and changes in personalities. These classic symptoms may be vague and may occur only occasionally in the beginning, with little behavioral impact. But as the disease progresses, the symptoms become more pronounced and are exhibited more regularly. Wandering away from the home and not being able to remember how to return increases. Some other effects may be delusions, hallucinations, and related behaviors develop and get worse over time. Spouses may become strangers. Patients may not even recognize themselves in a mirror. They wonder who is looking back at them. In its advanced stages, Alzheimer's disease may often causes incontinence, loss of control of bladder or bowels, and it may also result in a total loss of mobility, walking, transferring. People with the disease eventually become completely dependent on others for care. At that point, many caregivers seek facilities such as adult care centers and other sources of help, such as family and friends, to ensure a safe environment for the Alzheimer patient. These patients can't be left alone at times, so the primary caregiver needs relief to work or run basic errands. I can say that I have personal experience with this. My dad was diagnosed with Alzheimer's about 5 years ago. I know I talked earlier about the ways that you could be diagnosed, and we'll go over a little bit later about that, but it started off early as just forgetting how to do certain things. He forgot how he was used to be a fireman, electrician, forgot areas where he used to drive all the time, forgot how to wire, do basic wiring, would forget that he ate lunch, that they went to restaurants, kind of sparse at first, and then problem solving started to get harder. And then we went to a neurologist, and he did very well on some of the tests. Some of the short-term memory was hard. But then he got into a special funded research project where they actually are doing these high-level PET scans, CAT scans, where they actually were able to diagnose with the plaques. He's on medication, he's leveled off, and we've seen pretty stable in the last 3 years, but definitely repeating every day what's going on. So this time we can think about this isolation. It's been very hard for him. He doesn't remember at times why he can't see us, why he can't go out, why they can't go places. So it's reminding him all the time. He asked my daughter every time he talks to her on the phone, she's going to school the next day, even though she's been out 3 weeks. but yet can still dress himself, completely knows who we are, functions in the basic things. Definitely have some difficulty with word finding at times or reading books because it's hard to remember what you read earlier. So definitely, so I would say probably about 5 or 6 years he started showing symptoms, but definitely has been stabilized. We're at UCLA, a lot of research and stuff is being done. So some of the stuff I'm going to talk about in a little bit, there actually has been progress. So a day in the life of Alzheimer's is definitely challenging for the caregiver as much as for the patient. So rate of deterioration varies from person to person, but usually is around 12 years from the onset of symptoms. Although progression usually is faster when onset occurs earlier in adulthood, it is difficult to predict how long a specific patient will survive, which also adds to the caregiver's stress, right? So it's just one thing to think about. There's no set age group, and a lot of factors can play in it. General health. So if you're overall a healthier person, you can have better outcomes with Alzheimer's. If you already have heart disease and you're not very mobile, you're going to lose those a lot faster. So according to the book, Alzheimer's disease can only be diagnosed through brain autopsy after death. And this is documenting the number of amyloid plaques and neurofibrillary tangles. But like I said, my dad was diagnosed because he's actually part of research. They don't do this for just normal memory loss, but they have a higher level PET scan now, and he was just part of an early research project where they actually found the plaques before he had died. So actually they just thought he had early cognitive deficits, but we have a definite Alzheimer's definition because he was part of this study that was able to do that while he was still alive. So that, I do know that technology has come a little bit ways, but it's not available to all the population. So still the most common way and the most certain way that Alzheimer's is diagnosed is an autopsy. So that amyloid plaques and those neurofibrillary tangles are structure changes in neurons that occur normally with age, but occur in very large numbers much earlier in Alzheimer's disease. So they're still left with the issue, like I said, figuring out whether a person has Alzheimer's disease while she is alive. So most of the time before he had that, they couldn't tell him. They just thought he had cognitive deficits. So most people will get that until the things get worse. So when symptoms start to get worse, they'll have more, it's mostly a symptom diagnosed disease, but not a test type of neurological test disease. So again, although not definitive, the numbers and severity of behavioral changes lead clinicians to make fairly accurate diagnosis of probable Alzheimer's disease. So several brief screening measures have been developed, some such as the 7-minute screen showing about 90% accuracy. There's the mini mental where they have you remember items, 5 words. Can you remember 5 words? We've gone to UCLA, they've done a whole test on, he's done spatial testing, remembering letters with the letter F, being able to draw a clock, all these other things that show cognitive processing and memory. Alzheimer's disease is an incurable, fatal disease. Every treatable cause of the symptoms must be explored first. So Alzheimer's disease is essentially diagnosed by excluding all other possible explanations. And then the next slide is going to show how they do that. So this figure shows how diagnosing Alzheimer's disease requires a thorough process of ruling out other possibilities. So clinicians usually interview family members about their perceptions of the observed behavioral symptoms. Most clinicians view this information as critical to understand the history of the difficulties the person is experiencing. However, research indicates that spouses, partners are often inaccurate in their assessments of the level of their partner's impairments. In part, this inaccuracy is due to lack of knowledge about the disease. If people do not understand or know what to look for, they are less accurate in reporting changes in their spouse's partner's behavior. We had to do this with my dad. I'd go down with all his appointments with my mom. So trying to interpreting to my mom what they're exactly asking for. But because I have that experience, she's going to answer the question more correctly because I'm knowing what they're looking for. Some spouses, partners describe their partner's symptoms accurately, but family reports should not be the only source of information on a person's ability to function. So you can see some of the thought process and how Alzheimer's is diagnosed. So what causes Alzheimer's disease? Well, they do not know for sure the causes, but they've just found some trends. So early onset Alzheimer is considered before the age of 60, and that tends to run in families. You can actually get tested just like you can get tested for the brain cancer gene. You can get tested for the Alzheimer's gene. It's an autosomal dominant inheritance. So if you remember our gene, if you have its dominant one, means that if you have it, that means that you're going to get the disease. So it's a dominant, so you have 100% chance of the person getting the disease. So would you get tested right now if you thought you might have Alzheimer's? So it's a question, I don't know. I have to think about it. I don't really want to get tested, but something that to think about, right? Later onset after 60 may be linked to genetic risk and most commonly related to amyloid plaque formation. So the early onset version tends to run in families, right? We know that. Familial Alzheimer's disease is linked to 3 causative genes. So if you have one of these genes, symptoms always appear before age 60 and sometimes as early as the 30s or 40s. So with that, you know that if you, like I know I don't have that, those genes. Well, I don't know that for sure because I'm not 60, but if you make it past 60 and you don't have it, you probably know you don't have those genes. Later onset Alzheimer's disease may also be linked to gene risks, but the most promising research has noted links between the genetic markers and the production of beta amyloid protein. So much of this research focuses on the E4 protein associated with chromosome 19, a lot of fancy lingo there, but its central role is in creating neuritic plaques. So remember I said those plaques are what they find on the Alzheimer brain, and that's how they diagnose. So that protein causes more neuritic plaques. So in addition, they found that the related mutation in TREM2 may be involved with producing that protein. So when they have that extra protein, it impairs the brain's ability to contain inflammation, and then the brain dies. Interestingly, another version of ApoE2, that protein, seems to have the reverse effect, and it decreases the risk of Alzheimer's disease. So a lot of different research is done with proteins in the brain and how that affects Alzheimer's disease. Neuroimaging studies of people with Alzheimer's disease provide supportive evidence of the structural changes caused by the genes identified so far. Recent research has also focused on the role of that tau protein, which appears to be transmitted from neuron to neuron and is found in high concentrations in the neurons of individuals who die from Alzheimer's disease. This transmission across synapses could be the basis for new drug research. So all this stuff that they're learning helps them, there's no cure, but it gives them more information on how can we slow down the progress of this disease and maybe detect it earlier so that people can live longer before having symptoms. So currently there is no cure or preventive measure for Alzheimer's, and few medications show promising results according to the book. But I can say my dad goes to UCLA and he is on medications that they don't cure Alzheimer's, but what they do is they help slow down the symptoms. So what they do is help maintain his level right now. So they just slow down the formation of those plaques. So hopefully that his symptoms go at a much slower rate. But there are behavioral and educational interventions. There's space retrieval. Remember we learned earlier that EIO model, and it involves that implicit memory and internal aids. So that implicit memory is that, unconscious memory, that motor memory, right? So um, Alzheimer's patients can learn names of new people. So it helps them with that. But other programs bring in older adults and preschools to learn together. So the space retrieval involves teaching people with Alzheimer's disease to remember new information by gradually increasing the time between retrieval attempts. This is easy, and it's an almost magical technique that has been used to teach names of staff members and other information, and holds considerable potential for broad application. They found that it is superior to other techniques, and combines spaced retrieval with additional memory encoding aids helps even more. So in designing interventions for those Alzheimer's disease, the guiding principle should be optimizing the person's function. Regarding of the level of impairment, attempts should be made to help the person cope as well as possible symptoms. So what I find with my daddy is pretty good with this. He's accepted because even if he gets mad or frustrated, he forgets, and he forgets that emotion and forgets it, and it comes, later on he's over it. Whereas my mom remembers everything because, she's here. One thing I have learned in the rehab sense, that it's kind of reverse aging in physical and mental ability. So when they categorize Alzheimer patients, as they start to get more and more decline in function and brain activity, they actually revert to ages of children. So you can think of what a 10-year-old, what a 5-year-old, a 2-year-old, right? They eventually come into like a newborn in diapers, can't talk, can't say their name, So what we look at in rehab, and what you may look like in the healthcare field, is you want to teach skills when they're able to learn. So if a patient is still mentally capable, I'm going to practice with a walker in anticipation that they may need it soon. But I want them to practice when they still have some ability to recall and get that muscle memory. So when they aren't able to learn, they'll still remember it. Because remember, we can say that implicit memory. And it's also to give good support to the caregivers while they're dealing with this. So let's go and talk about Parkinson's disease now, which is a brain disease known for its characteristic motor symptoms. It's very slow walking, kind of that rigidity. They call it like a cogwheel rigidity. It's kind of like if you were bringing your arm up, it kind of has that like rigid movement. Difficulty with initiation, getting into and out of chairs, slow hand tremor, may have a resting tremor, and actually you can develop into a form of dementia, which they call Parkinson dementia. So it's that really shaky tremor, shuffle gait, difficulty with initiation. And it's caused by a decrease of dopamine. So again, a neurotransmitter. There's deterioration of neurons in the midbrain that produce that neurotransmitter dopamine. So you can think of people that had Parkinson's, right? Muhammad Ali, Michael J. Fox. So watch videos or look at them, and they're a good example of what people with Parkinson's disease look like. Over 1 million people in the United States and over 4 million globally have Parkinson's disease. Symptoms of Parkinson's disease are treated effectively with two primary approaches. You want to think medication and surgery. So the most common medications are levodopa, which raises the functional level of dopamine in the brain, right? So that we think about that neurotransmitter, they don't have enough of it, so you're going to raise it up. Cinnamate is a combination of levodopa and carbidopa, which gets more levodopa to the brain, and Stalevo, which is a combination of cinnamate and entacapone, which extends the effective dosage time of cinnamate. All you really need to know is that levodopa is the medication base, and it's going to help increase the level of dopamine in the brain. The second thing is surgical interventions involve using a device called a neurostimulator. And what it does is it acts like a brain pacemaker. So they put little electrodes implanted deep inside the brain, and it actually helps decrease the tremors when stimulated. Research indicates that a neurostimulator may prove effective in significantly reducing tremors, shaking, rigidity, stiffness, and walking problems when medications fail. For reasons we do not understand, some people with Parkinson's disease also develop the severe cognitive impairments and eventually dementia. So remember, dementia is a set of symptoms of, it's not a disease. And as with Alzheimer's disease, attention is focused on those beta amyloid protein levels as a possible cause. But, much research needs to be done to understand that more. So the last thing we're going to talk about is chronic traumatic encephalopathy, CTE, which is a form of dementia caused by repeated head trauma such as concussions. So it's that repeated damage in the brain where with the concussion, the brain hits in the front part of the skull back to the back part of the skull, and with that causes brain tissue damage. It occurs as a result of repeated brain trauma they found in sports, military, and combat. And they found that 14 of 15 brains of former NFL players showed evidence of CTE, and that's at the time of this book. I have a video attached here that kind of will explain it a little bit more, and actually has data on new information of many, many more football players. CTE can occur as a result of repeated brain trauma, not only in sports, but also through other causes such as military combat. Emerging evidence shows that irrespective of the cause, there is structural damage to various parts of the brain that have to do with executive functions and memory. And you can imagine if the front of your brain is being hit and damaged, that's where all your emotions and your reasoning are. So a lot of suicides. Although there is evidence of severe cognitive problems in some people who experience repeated brain trauma, at this point there is controversy regarding whether CTE is a separate disease or a variation of other disease. So a lot of research still needs to be done, but there has been a lot since this book has been published. So make sure to watch that video, and it's going to show a lot more explanation of that. And the next slide, I'm actually going to show you what it looks like on the MRI. So what you're looking at is the MRI images of CTE and dementia. So you can see, and the first one is a non-contact sport. So that would be your normal. Then the middle is the athlete is a contact sport. And then the last one is dementia. So in the middle one, in the CTE image, notice the shrinkage of the brain matter. You can see a lot more space, empty space compared to the normal one, especially in that frontal cortex. Probably that's a cause for many suicides and poor judgment. And then you look at the dementia brain with its really enlarged ventricles, and that's putting a lot of pressure on the brain matter, which causing a lot of cognitive deficits. And you can see that that hippocampus is really, really atrophied. So there's a lot more black space in there. So just looking at between the normal and that CTE and dementia brain, you can see why they have all those cognitive deficits. So I have a video on Alzheimer's, and I have a video of CTE, and also I have a video of the Parkinson's with the neurotransmitter on it for you to look at. So watch those. They're very, very short, so it gives you a really clear picture of these. And again, I will take some question from them. So that's chapter 14. That's the later adult. A lot of things changing, a lot of cognitive issues, a lot of brain issues, physical health changes. And then remember, this week you have your tests, you have your homework quiz and your discussion group, and I will see you again on chapter 15. Have a good week.